Hello and good evening, friends. Welcome to yet another edition of ACNS webinars. Today's webinar is very special for us as it features the 99th and 100th lecture since we started our online journey of neurosurgical online education in June 2020. So let me thank you all the viewers and the faculty who supported us throughout this journey in achieving this feat. And there can be a better way to celebrate this occasion of our centennial lecture than featuring two great speakers today. The first speaker for today is our honored guest from Arizona, USA, Professor David Adelson. Professor Adelson is the Chief of Pediatric Neurosurgery, Director of Barrow Neurological Institute at Phoenix Children's Hospital, Diane and Bruce Haley Endowed Chair in Pediatric Neurosciences. Dr. Adelson is a globally recognized expert in the area of pediatric spine, brain, spinal cord, peripheral nerve injury, in particularly acute clinical management of traumatic injured children, as well as regenerative and restorative neurosciences. He continues to participate in an active basic science laboratory in translation neurotrauma with a focus on neuroplasticity along with collaboration at Arizona State University in neural machine interface. He has more recently expanded his research focus into the areas of mechanisms of epilepsy, neural recovery, neurocritical care, and restorative functional neurosciences. He is the recipient of multiple awards during his vastly experienced career. He was the first pediatric neurosurgeon to be awarded the highly coveted Herbert Oliver Krona Award, considered by some to be the Nobel Prize in Neurosurgery by the Department of Clinical Neurosciences, Neurosurgery at Karolinska Institute, Stockholm, Sweden. Dr. Adelson is the coordinator of committee activity for World Federation of Neurosurgical Societies. Dr. Adelson's research has resulted in authoring more than 210 peer-reviewed journal articles, 40 book chapters. He has also edited 8 books, including the well-regarded Principles and Practice of Pediatric Neurosurgery. We are extremely honored today to have him as a speaker at our webinars. He is going to talk about epilepsy surgery in children, innovations in diagnosis and treatment. The second speaker for today is our honored guest from India, Dr. Abhida Shah. Dr. Shah is an associate professor of neurosurgery at the St. GSKEM Hospital, Mumbai, India. She holds high levels of expertise in skull-based neurosurgery, vascular neurosurgery, open and endovascular, craniovertebral junction disorders. Dr. Shah is a versatile speaker and is an integral part of the world neurosurgical education and online lectures organized by various societies around the world. She is the associate editor of the Journal of Craniovertebral Junction and Spine. She is a noted author who has published several manuscripts and book chapters in neurosurgery. She has been working along one of the great leaders in world neurosurgery, Professor Atul Goyal, for several years, and hence the inspiration and influence is tremendous that today she is going to talk about revolution in surgery for OPLL, the Goyal hypothesis of instability as a cause and stabilization as a treatment. We are extremely honored to have her today as a speaker at our webinars. The chair for the first lecture of today is Professor Sanford Su from Taiwan. Professor Sanford is the Director of Neuro-Oncology, Cerebrovascular and Skull-Based Neurological Institute, Taipei Veterans General Hospital. He is also the Associate Professor at National Yang Ming Chiao Tung University. He is the visiting professor at University of Virginia, USA since December 2013. He was the Vice Secretary of the Taiwanese Neurosurgery, Neurospine Society and Taiwanese Neuro-Oncology Society. He was a former fellow with Professor Ali Krisht, Professor Al-Mefti and Professor Yashar Gil. His keen interest in the field of epilepsy surgery stems during his fellowship days with Professor Yashar Gil. He is a noted author with several publications in various peer-reviewed journals and book chapters. We are extremely thankful to Professor Sanford for accepting our invitation to chair this webinar. The second chair for today is Professor Kanda Raslingam from Malaysia. Professor Raslingam is the consultant neurosurgeon at the Prince Court Medical Center, Kuala Lumpur, Malaysia. He is the president of the Neurosurgical Association of Malaysia and was also the past secretary and vice president. He has a keen interest in spinal surgery and had numerous attachments and fellowships in Malaysia, Japan, and Korea. He has organized many courses, both brain and spine, and was the organizing chairman for the first Neurospine Congress held in 2016. He also conducts yearly spinal courses for training postgraduates as well as young neurosurgeons. We are extremely thankful to Professor Kandaras Lingam for accepting our invitation to chair this webinar. On behalf of the Education Committee of the ACNS and the President, Professor Yoko Kato, I would like to welcome both the chairs and speakers for today to this online platform of ACNS webinars. Dr. Liu Boon Seng from Malaysia is my co-host for today. And with that introduction, may I please hand over this virtual platform to Professor Sanford Su.
Yes, thanks, Dr. Raja, for introduction. And it's my pleasure and honor to chair the first talk by Professor David Adelson. Today, his topic will be the pediatric epilepsy surgery. And welcome, Professor David.
Thank you so much. I'm just going to share my screen here. It's truly an honor to be here, and it's a wonderful invitation. And thank you for that wonderful introduction. Um, I'm hopefully going to provide for you today. I didn't want to do sort of a review of epilepsy surgery because I think many of you are familiar with it. But what's really been exciting for me through my career, and I'm sure along with Professor Shu, is the fact that we've seen so much great new technology and new innovations that have really opened up the opportunities. And in my opinion, and I think many others, is that waiting until adulthood to treat epilepsy in patients is really detrimental. And so what I hope to impart to you today is that there has been great innovations in diagnosis and treatment that really allows us to get more quickly an understanding of the etiology of these patients' epilepsy, and then hopefully bring to bear new treatments that will give them a better lifetime without seizures. Just as a disclosure, I do some consulting work for Medtronic, and I will try to keep any conflict out of my talk. So as I mentioned, the surgical treatment of epilepsy really has been around a long time. I mean, the first descriptions of epilepsy surgery are from the 19th century, and now we're in the 21st. And to think that, as I mentioned, for the most part, with good patient selection, there can be good to excellent outcomes that have been achieved, mostly in adults, but also commonly now in children. We have to realize, though, that epilepsy is the most common neurological disorder of childhood with an incidence of about 2%. So there's a vast number of children that are suffering from seizures and epilepsy. And I'm not trying to push surgery as in replacing medication, but really should be considered when when medication does fail, and surgery should be introduced to these families early on, so that indeed these children do have some potential for cure or at least treatment. I have a number of takeaway points that I'm going to share with you today. I think that clearly we can all agree that the best outcomes come with accurate localization of the epileptogenic zone and or the network. And so with that, I'm going to talk about diagnosis and targeting. Our newest innovations have really been in the solutions of improved diagnostic accuracy. So I think that that's something that I'll touch on here as well today. And the more kind of the newest technologies and newest innovations surgically really leverage that accuracy and allow us to improve outcomes, lessen morbidity, and really try to bring to bear a greater population of patients that would benefit from surgical intervention. And then I'm also going to touch on neuromodulation, because I think this is a wonderful potential horizon that has been around for a number of years, but now with new techniques and again, new targeting, we can now provide again opportunities for further treatment for this very difficult population. Well, suffice it to say, and I don't need to kind of remind this audience that when patients are first diagnosed with epilepsy, we can for the most part get them seizure-free about half the time with the first drug. So significant percentage of patients will be responsive to medication and be able to go on with their daily lives. Unfortunately, the other 50% who are not seizure-free require, let's say, further drugs or further medication. Well, when we introduce a second medication, there's only about 11% chance of becoming seizure-free. And then if we have to add a third drug or multiple drugs, there's only about now a 4% chance of improving outcome. So all told, it's about 65%. So that leaves a vast majority of patients who would be considered refractory. And if we sort of look at that, at least in the United States, where there's about 3 million people living with epilepsy, That means that there's about 1 million patients who are considered refractory epilepsy patients living in the United States. And if we looked at the numbers of how many surgeries per year are being performed, only about 7,000, you can see that there are a substantial number of patients, and particularly children, who are not receiving adequate treatment. And then if we start to think about the average duration of some of these patients who are waiting to have surgery or waiting to get appropriately diagnosed, many times they have upwards of 20 years of intractable epilepsy before they come for surgery. And then lastly, if we look at the number of new cases per year, and that there's about 50,000 new cases of intractable epilepsy that are diagnosed each year, you can see that we're not only going to be able to not dent this number here, but we're also not even going to have any impact on new cases that are rising each year. So I think that this is a vast problem with really vast opportunity for those who become interested. But even with data that shows the value of surgery, and now this article has been around for 20 years, the reality is, and many of you who are interested in epilepsy surgery can attest that many times the difficulty is just getting the patient referred for evaluation. And so I think that despite the science where morbidity is less and mortality is less, that indeed we really do have to do a better job in getting these patients referred for surgery. Well, some of the complexity of defining what is really the patient that would benefit from surgery or not really was around this concept that, well, in adults it was easy. They had complex partial seizures of the temporal lobe in a very localized area, the mesiotemporal region, amygdala hippocampal. And for that reason, this was a group that was treated aggressively in the management of their epilepsy. But in children, we often deal with a lot of different seizure types. There can be a lot of different semiology. Many of their seizures are extratemporal or cortical. They're not small and foci. They often have numerous seizures per day, so when they get a medication, wow, if they're not having 50 seizures a day, now they're down to 5. That seems like a marked improvement, but that's still 5 seizures a day. And the impact of the epilepsy on their cognitive and behavioral development, whether due to toxic levels of medication or ongoing seizure disturbances, really do have a significant impact in the long term. So the goals of epilepsy intervention, whether it be medical or alternative treatments or diet or surgery, are to stop the seizures. And the goal for that is really to prevent further brain injury or interference of normal function so that these patients can go on and have a better quality of life and have jobs or other things that they ordinarily may not be able to do. And in children in particular, by stopping the seizures, what we hope for is for normal neural development, allowing them to go to school, to allow them to progress, and to go on and have meaningful quality of life. So we know that surgery is best recommended for those patients to try to achieve a cure. But is a cure the only thing that we need to shoot for? And that's really part of the question when we are discussing this large population of intractable seizures. At least for resective surgery, patients preferably have focal onset seizures, so a localized zone of where the seizures are arising, a focus in a region of cortex safe to remove, so non-eloquent cortex, and they should be drug resistant, so they need to have failed at least 2 or 3 medications. Now, this is a definition that's been around for a number of years, but many of you have, I'm sure, experienced the fact that sometimes you're getting patients who've had 10 years of seizures, have been tried on 10 different medications, and now they finally are referred for potential for epilepsy surgery. Well, with regards to the decision making, as I mentioned, the best outcomes come dependent on the seizure type. If we can lateralize and localize the seizures, and particularly if we can identify a lesion, but even if they're non-lesional, if we can identify the dysfunctional area, so our ability to visualize either the anatomical abnormality or the functional abnormality will allow us to get the best outcomes for this population. And clearly, it's the identification of the epileptic focus or seizure onset zone that allows us to potentially treat these patients the best. Well, there's a lot of new technologies for focus localization, and I'm not going to go over all of these because that would take up the whole time. But suffice it to say that clearly, when we look at the last 5-10 years, and you think about imaging, and you think about the roles of neurophysiologic monitoring and all these different things, we are now much better able to not only identify where the sources are, we're much better able to identify lesions and abnormalities that we couldn't see before. We have better functional imaging. And lastly, we also have a way for us to identify where there's eloquent areas of cortex and no longer depending on WADA testing. So let me briefly go into neuroimaging. I mean, if we look at old generation of MRI scans and we look at older sequences, you know, we might look at this MRI and say, oh, that looks pretty normal. There's not really any issue there. But clearly with the advancement of new sequences and changes in how we approach this, we can now start to see abnormalities that we couldn't see before. We can now start to localize these better. And so as a result, we're now able to start to target our hypotheses as to where these patients' seizures might be arising. And then we can start to do much more deep levels of analytics with big data. We can start to look at where there's cortical thickening. So this patient had a normal MRI, but now with cortical thickness analysis, we can start to look at where there's abnormalities relative to healthy controls. And so now we can look at potential areas of cortical dysplasia where there's abnormal thickness of the cortex that we wouldn't see before. Here you can see the precentral gyrus, and you can see in this patient, this is an overlying grid that we had placed and depth electrodes for this patient, but you can see where we're starting to think about mapping not just function, not only normal function, but also the relationship of abnormal anatomy that we couldn't image before, but now we could potentially image. And then clearly with being able to develop tractography, now we might be able to develop understanding or allow us corridors for safe surgical interventions, particularly when we want to do more minimally invasive approaches. But the reality is that epilepsy is a functional disease. It's an abnormal function of the brain. And for that reason, when we think about dysfunction, we have to use functional imaging in order to visualize that abnormality. And there's a number of different modalities that are available. During my training, PET scanning was developed and widely utilized in order to look for temporal lobe abnormalities, and you can see significant hypometabolism, very straightforward. If there was EEG correlate and anatomic imaging correlate, and now functional correlate, here was a patient that would go directly to temporal lobectomy. But now we can take multiple modalities and map them one on top of the other, and here MRI and PET can be used in order to identify the dysfunctional area, but then allow us some opportunities for anatomical targeting when we consider surgical intervention. And so is this a place, an area that we could potentially go to and remove and improve this patient's outcome? Or is this a place that we might consider for neuromodulation if it was not a safe area for resective surgery? SPECT has been around a long time looking at blood flow, but interictal SPECT was not particularly useful. Ictal SPECT, there is some logistical issues, but could be potentially useful with good sensitivity and specificity. But with new technologies, now we can do what's called a subtraction image. And so you can actually subtract the ictal, the interictal from the ictal, and you can then get a very targeted approach. And now if you can marry again the imaging and put this overlay onto your MRI, now all of a sudden you can see a very targeted area of a potential seizure onset zone that might be a great target for either minimally invasive resective surgery or something like a laser ablation, or again, if it's in a motor area, consideration for neuromodulation. So, and also again, we can use functional imaging now to look at function. So in my day, when I started, it was about WADA testing, and this was patients getting pentobarbital injection directly through angiography into major vessels in order to put that portion of the brain to sleep and then try to do tasks. Well, we've progressed since then, and now with functional MRI, we can now start to do those tasks in the MRI scanner and start to identify areas of eloquent cortex. And so we are able to start to look at regions that allow us to better plan for potential surgical intervention. But the reality is that functional MRI has two limitations. One is it's not yet reliable for imaging memory. And secondly, it's very difficult to impossible to do in children. We cannot get a 5-year-old to stay in place, not moving around within the MRI and try to do task-based functional imaging. But it is very useful. Here's a patient with a tumor, and this was a DNET, and we were able to map out in this particular patient a location of where indeed their motor functions were relative to this lesion. Well, now with the advent of resting state fMRI, we can now start to look at the functional organization of the brain at rest, and it can be done under sedation. So now we can start to look at regional interactions without actually having to do tasks. We can look at networks, normal networks, and we can also look where there's absence of networks, and we can look for areas where there's abnormality or where there are networks that would correlate with potential seizure foci. So indeed, we can look at functional networks, and here looking at motor and attention and visual, again, using resting state. We can look at language networks, and so we can see dominance here, left-sided dominance compared to right. But what's interesting about resting state, and what we have already known from more primitive testing, for lack of a better word, is that many times language is on both sides. It's just that one side is more dominant than the other. In children, we can see that their language networks form very early on bilaterally and then shift toward one side or the other. And so now we get an opportunity with resting states to see actual neural development in children. But we can also localize abnormal seizure network or abnormal neural networks. And so here, left temporal lobe, and you can see this abnormal network outlined here in the left temporal lobe. We can start to look at relationships, very similar as I showed with the task-based MRI. We can start to look at where there might be a seizure network relative to a temporal lobe tumor. And so if we want to try to treat this patient's tumor and try to treat their seizures at the same time, here's a way for us to do a more targeted approach. And so really, I think the resting state provides us really unique opportunities, which I'm going to show you also its relationship when I talk about surgical options. Well, we've also come a long way with regards to surgical options. With regards to invasive monitoring, many of you may remember, to consider depth electrodes, we had to really, the indications were that we didn't have an ability to lateralize or localize the seizure focus adequately. There was non-concordance of data. So did the EEG not match up with the anatomy, et cetera? We didn't know where functional eloquent cortex was. And so for that reason, we would consider potentially different methodologies for invasive monitoring. And there are a number of them, and I won't belabor these. But suffice it to say, in my day, it was all about depth electrode placement. And when I started, this was my, not this one, but this was the techniques used in my first case as a neurosurgical intern, and we used pneumoencephalography. I'm sure some of the older neurosurgeons out there would get a laugh out of that, but we used pneumoencephalography and angiography to decide which side had mesiotemporal sclerosis, and then could we then target different areas using these very large bolts to place orthogonal depth electrodes. And so we've come a bit of a way. Here's a young man who had this lesion, but his EEG showed frontal seizures. We did MEG on this patient. This would be a typical MEG that we might see and target that particular location. We then could use our strategy to place a series of SEEG electrodes in that location. But again, we were dealing with someone where we were getting indications that it was bilateral. This is early in our experience with MEG. So we placed depths on both sides, but it ended up being exactly correlative, and we were able to do a very limited resection in this patient who was and went on to be seizure-free, as well as it was a low-grade glioma, no further recurrence, and had a little bit of weakness early on, but really with occupational therapy recovered full use of their arm. With regards to other targeted treatment options, again, if we go back to when I started, this was the extent of what we could do in epilepsy surgery. But the results were good. We could actually get 80 to 90% of patients with temporal lobe epilepsy and make them seizure-free. We could make them, we could have improved outcomes with temporal lobe epilepsy, maybe less so with frontal or parieto-occipital lobe, but again, still good outcomes if we were able to target those particular areas. And we knew that, example, that mortality was less with surgery compared to letting them continue to have intractable seizures, because unfortunately we do lose patients each year because of SUDEP, sudden unexplained death of epilepsy. Well, as I mentioned, this is where we started. Now we can do more minimally invasive approaches like a hemispherotomy. We can do ablation of particular areas, and so now more minimally invasive approaches for resection or cure. And then we also have neuromodulation, and I'll touch on a few of these in the rest of my time. Just with regards to laser ablation, we introduced this a number of years ago. It can be either frame-based or using robotic instruments. Again, this is placement of a laser probe into a targeted area. You use MR thermography of that targeted area, along with safety markers for local and nearby vital structures. And then with that, we can start to target these different areas. This really came into being when we sort of started to deal with things like hypothalamic hematomas. This is a great example. Here's a 14-year-old young girl who recently came to us about a year or so ago from Hawaii. She had gelastic seizures since 6 months of age, but had really been living 13 years with intractable epilepsy. She'd been tried on 10 different medications with no impact, and eventually came to our center in Arizona for evaluation. Here's her imaging. You see the beautiful MRI anatomical delineation of the hypothalamic hamartoma. We can see normal structures here, the mammillary bodies, along with its relationship to the hypothalamic hamartoma. Here's looking at the sagittal image, again, the HH, but also here, the mammillary body and the fornices in relative to this area of abnormality. We did a resting state on this patient because we were very interested to know what, in some instances, these patients have the relationship between the HH goes temporally, and they have complex partial seizures in relationship to their gelastic seizures. In this patient, they were more generalized. The actual directionality of this particular seizure network was posteriorly, And so we ended up targeting the more posterior portion of the HH. You can see that here with our laser probe placed. This would have been a patient who either went through an interforniceal or an interhemispheric approach, or either intraventricular endoscopic approach. But here we were able to place the laser probe right into the abnormality. Here's the damage maps right at the area of where our networks are. We were able to avoid her mammillary bodies down low here, as well as the posterior fornices around the back end of the hypothalamic hamartoma. And this patient has done very well. She's now seizure-free 1 year out from her laser ablation. Here's another patient. This is a 17-and-a-half-year-old young woman who had febrile seizures at 8 months of age. She went on and had very typical temporal lobe epilepsy with complex partial seizures. She had imaging with a mesotemporal sclerosis. Luckily, she had right dominant language, but everything pointed toward her left mesiotemporal lobe. Here's her imaging showing the mesiotemporal sclerosis. And then here's the laser probe you can see here, and the damage map for her laser ablation. And again, another patient who's gone on and done very well. The nice thing about laser ablation in these patients is that you can always go back if they stay only overnight. They're no prolonged hospitalization, and if necessary, you can always go back and re-ablate if there's an area that was not adequately targeted or not adequately treated. We have had one patient where we tried a laser ablation twice, and then we went back and did a standard temporal lobectomy. Here's just the post-ablation map of the DWI in this patient, as well as the T1s with contrast, which show basically the removal of the mesotemporal structures just using laser ablation. Here's a patient where we did who had a focal cortical dysplasia. You can see the damage map in this location, as well as the post-ablation imaging. Here we used actually 3 probes to obtain our damage maps. And then again, starting to think outside the box and new innovations. This is a patient with Lennox-Gastaut, multiple seizure types. Would have been somebody that we would have recommended for a corpus callosotomy. This is the surgical view of the corpus callosum that you can see with a small craniotomy. Here's the intraoperative view, pre and post disconnection, but now with the potential for laser ablation. Here's what was to us a very amenable corpus callosum for laser ablation. Here's probe in the genu, one along the anterior portion of the body of the corpus callosum, and then one posteriorly extending into the splenium. And we were able to get a complete callosotomy in this patient. Again, just a couple of days in the hospital, and was able to go home and was no longer having his dropped seizures. And these are just the post-ablation maps showing the extent of that laser ablation. Well, I'm going to go lastly in my time to going on to neuromodulation. The reality is that not all patients are able to have a resective or removal of their seizure focus. Now, whether it's an eloquent cortex or it's so diffuse, we really do have a significant number of patients that would not otherwise be candidates for surgical intervention. But with the advent of neuromodulation, we've now started to really provide new opportunities for these patients. There's now a number of different technologies that are available, or hopefully in the future when it comes to maybe cell transplantation. But now a lot of these are in the mainstream, at least the first 3 or 4. And then I think that in the future, we'll start to see more TMS and other technologies that may be able to help this group of patients. I'm not going to review VNS because it's been around for over 20 years, but we now show, now there is now data that shows really the long-term benefit of these patients. Upwards of 64% of patients are getting a better than 50% reduction in their seizures. And for some of these patients that are quite devastated by their epilepsy, that this is a significant impact. Clearly better than adding another medication where there's only about a 1 to 4% chance of really improving things. So indeed, VNS has been a real boon when it comes to really opening up the eyes of our neurology colleagues to the potential benefit of neuromodulation. But I'm going to talk a little bit about deep brain stimulation. DBS has been around a long time now for movement disorders. Really being able to target locations really has been the boon for movement disorders and being able to target those. But we recognize that there are multiple dysfunctions of the brain, and including epilepsy. So whether it's a movement disorder, whether it's due to psychological or psychiatric disorders, there are multiple potential targets, and that's the reason that DBS, or deep brain stimulation, has really had such a growth over the last number of years. Well, with epilepsy, there was recently, at least in the United States, data that allowed for approval of bilateral anterior thalamic nucleus targeting for patients with medically intractable generalized epilepsy. But the reality is that there are still patients that don't have specifically bilateral generalized epilepsy. And so we need to look at ways that we might be able to better target these patients in the future. Again, there are different options, and NeuroPace is another company that has used invasive neuromodulation in order to do stimulation. They have a closed loop system whereby they're reading when the seizure occurs, then giving a stimulus back to areas of where the seizures are believed to occur. So if this is our seizure onset zone, we could potentially bracket that area. If a seizure is, this device learns when the seizure is detected, it will then give a stimulus back and try to arrest that seizure or keep it from spreading. When there's not a localized area of brain, the possibility exists that we could potentially place a deep brain stimulator, let's say with that's been standardly used for movement disorders. And in those instances, we might be able to get better characterization. As well, we start to recognize that there are different cortical connections. And so we know that the anterior nucleus is connected to the limbic system, and so may indeed be better for patients with bilateral hippocampal or amygdalar seizures. We know that the centromedian nucleus is more often connected, or is connected, highly connected to widespread cortical regions, somatosensory regions, particularly in the frontal cortex. And we also recognize that the pulvinar has greater connectivity posteriorly. And so should we be targeting different nuclei of the thalamus if we're going to consider deep brain stimulation for epilepsy? There's now a number of studies that have started to look at the different nuclei with reasonable results. And again, looking at different regions by which the cortical leads are placed. Here's just a single center case series of 7 patients targeting centromedian, where all 7 patients got a greater than 50% reduction in their seizures with DBS placement into the centromedian nucleus. So this was a recent patient of ours. This is a 15-year-old young woman who had seizure onset at 10 years of age due to autoimmune encephalitis. She had multiple seizure types, including independent left and right onsets. Interestingly, she had a right amygdalar and a left cortical, so independent and not symmetric or complementary. And so for that reason, we were really left with a dilemma on what would be the best targeting in this patient. We did SEEG in order to identify those targets. Here's the series of SEEG electrodes that we placed, as well as the brain regions where, again, we also used high frequency oscillations as part of our diagnostic. I didn't mention these, but now we can do looking at the neurophysiologic to do better source localization. And you can see different regions of the brain that were affected and where we saw very significant electrophysiologic abnormalities and in different times, different locations. And for that reason, in this patient, we ended up placing one surface electrode, right temporal. You can see the wire going, but here it's amygdala target, as well as a central median nucleus target as well. This patient has gone on to do very well. We've been able to reduce her seizures. She's only 2.5 months out. We've been able to reduce her seizures already by about 50%. So in summary, I hope that I've shown you today and allowed you to recognize along with me that the reality is that intractable epilepsy significantly impacts mortality, morbidity, clearly quality of life. We all have that experience. The reality is that surgery does do better rather than continued failed medical therapy. And so if patients have been tried on 2 or 3 medications, if they have failed ketogenic diet, if they've failed alternative treatments, really surgery is really a great opportunity for us to improve all of their lives. The exciting thing for me has been I've had to retrain and learn new technologies and new advancements, which I hope keeps me young and extends my career. The advancements that we've had, as I've shown you from when I started to where we are today, is really in the ability to localize the seizures better, whether it be now with functional imaging or with neurophysiologic types of monitoring like high frequency oscillations or MEG, but also the identifications of networks. Similarly, we've had such great advancements and innovations in surgical opportunities that I think that the opportunities for these patients has greatly expanded and really allows us to have a unique impact on all of these patients. I could not do without a great team of necessary to be able to define these patients, identify the best patients, the best targeting, and it's really a tribute to this whole group that we fortunately have here at Phoenix Children's in this regard. So with that, I thank you and I look forward to our discussion.
Yeah, thanks, Professor Debbie, for the excellent lecture. And I have some questions for you. Usually for the neurosurgeons starting doing the epilepsy surgery, usually we had a common problems. Most of the first one is for the non-lesional general epilepsy. What do you usually work for differential diagnosis? For example, maybe you have to check if it's the metabolism disease or genetic disease. What's your usually work for differential diagnosis?
Yeah, that's a great point, Sanford. You know, I didn't go into that here. I tried to give a little bit of a higher level, but you're absolutely right. I mean, we're doing almost all of the technologies that I introduced for diagnosis we do here. That diagnosis, as you pointed out, includes sort of the standard, you know, semiology, imaging, EEG, video EEG, but now we do, you know, full battery of neuropsychological testing. We do genomic panels. We really do look for an opportunity for us to define whether they're pure generalized or is it generalized that we just are not identifying the seizure focus or localization. So if we get to the point, even with patients with genetic syndromes, if we're not sure, if there looks like one side's predominant, we might go ahead with SEEG electrode placement in order to define indeed whether they're generalized, or we might go to a low risk, potentially high benefit, go right to a vagal nerve stimulator, because that's an outpatient procedure and patients do very well with it. And I've really had very, very few patients complain about the stimulator, especially if it's controlling their seizures. The only patients that have complained have been my adult patients. So it's, the kids put the stimulator in, doesn't bother them, they go about their usual day, which is actually the fun part for me in dealing with children.
Yeah. And the second question is, for most of neurosurgeons, we would like to know what's the best, a good outcome predictors for the epilepsy surgery. So for you, do you think is any one or more common outcome predictor for the epilepsy surgery? For example, for the focal cortical dysplasia, what do you think, which one is the best for outcome predictor, or tuberous sclerosis? Do you have any idea?
Absolutely. Well, I mean, the reality is that mesiotemporal sclerosis is our best indicator for a great outcome. I mean, in the well-chosen patient with early epilepsy. So if I get a 5 or 6 year old with who had febrile seizures and has MTS, unilateral, right dominant, right-sided, left dominant, that's a child that I'm going to enjoy taking care of, because they're going to have a great outcome and go on and lead a normal life off medicine. Those are the best. Cortical dysplasias are more complicated, as is tuberous sclerosis, because they're not. We can find one area of cortical dysplasia, and I pointed out one area. I mean, that was insular. That's very complex. But the reality is that if they have cortical dysplasia in one location, they likely have cortical dysplasias in other areas that we don't see by imaging, by anatomical imaging. Now, as I pointed out, we're starting to do cortical thickness maps. And so we can now start in all of our patients with cortical dysplasia or tuberous sclerosis. We're doing those cortical thickness maps in order to try to identify other areas which may be suspicious for either tubers or for thickness, so that if we had, for example, if we just looked at anatomic imaging and we saw that there was a dysplasia, and then we got the EEG and it showed that the EEG abnormality was elsewhere, and then we would say, wow, there's not a concordance of the data. But now when we do these cortical thickness maps, all of a sudden that area maps onto an area where indeed there is likely a cortical dysplasia. We're just not seeing it as well. And also, we've got a wonderful chief of neuroradiology, well, he's now chief of radiology, who really has taken a much more careful look at looking at the cortical ribbon and making comparisons. And he's really become adept at us being able to pick up suspicious areas of dysplasia. And so now we're marrying our cortical dysplasia analysis on with his subjective look, and we're finding very nice correlates. And so now I think with machine learning, we're going to start to be able to pick these things up even more from subtle imaging differences.
Yeah. And the third question is, usually the common situation is the surgical timing. For example, for Rasmussen disease, when you decide to do the hemispherotomy, but in consideration of the cognitive function and development process, so usually on your mind, what's the best timing for the surgery?
Well, a lot of my work, has been done in looking at neuroplasticity, and obviously, ideally, we would do any major surgical intervention which could potentially lead to neurodysfunction in the younger the child. So if I could do it in a 4 or 5 year old, they're going to likely have a much better outcome than a 14 or 15 year old. Unfortunately, it's when they develop the Rasmussens. I do know that, I took care of a patient recently, and the family just kept holding out hope that the child was going to get better. And we tried, IgG and immunotherapies and things like that. And they didn't work. And this child was just in status and in coma multiple times. It took, the family upwards of a year to really decide to finally go to a hemispherotomy. And now she's seizure free, but she's really neurologically devastated from when she started because the contralateral hemisphere was just damaged by all the seizures and everything that was going on. So, I'm really, we try to run through things early and to try to be very aggressive when we identify it. Usually I'll start with an area where we see signal changes already in the, let's say, the temporal lobe, do a temporal lobectomy. It'll show Rasmussen's. If they continue to have seizures, we try to encourage the family to go right away to a hemispherotomy. I think with newer techniques, more less invasive ones, I think we've gotten better at being able to convince them and get the patients out quicker. I mean, my anatomical hemispherectomies back when, would be 2 weeks in the hospital in a shunt. Now with the hemispherotomies, they're out. My last patient went home in, 3 or 4 days. So, I think that, these type of surgical interventions really have been a boon toward improving quality and opening up which patient should come to us. And really, I think convincing the neurologist to let us do the surgery. So
thank you, Professor Devi, for your beautiful lecture. Thank you.
Again, thank you for the invitation. This was a wonderful honor for me.
Thank you so much. That was a wonderful lecture. We learned a lot today. I would like to invite Professor Kandaras Lingam, who is the chair of the second lecture, to say a short introduction and invite Professor Abhida Shah.
Good evening, Dr. Raja and everybody. Thank you to Dr. Professor Yoko Kato and the team from ACNS to give me this opportunity. I'll be introducing Dr. Abhida Shah, who is Assistant Professor of Neurosurgery at St. G.S. Medical College and KM Hospitals in Mumbai. And she will be talking today about surgery for OPLL. Now, this is something that is it's a very, very interesting topic. And I see that, she's talking about the Goel technique. And, so it is something that I think Professor Goel has been advocating for some time. And a little bit more introduction about Dr. Abhida. I think she has got her interest in skull-based neurosurgery, vascular neurosurgery, and also CV junction. And I'm sure she's going to, this topic about OPLL is quite prevalent in the Asian community, and a lot of studies done in the Asian region. So I will pass it to Dr. Abhida Shah now to present, and then maybe we can ask her some questions after this. Thank you. Please proceed, Professor Abhida Shah.
Thank you, Dr. Kanta, for this nice introduction. And thank you to Professor Kato and ACNS for this opportunity to make this presentation. Can you see my screen?
Yes.
Yes, please go ahead. Yeah, carry on.
So I'm going to be talking today on surgery for OPLL in particular and discuss our strategy for cervical spondylosis in general, the Goel hypothesis of instability as the problem and stabilization as the treatment of spinal degeneration. So before I begin, I would like to bring attention to the small article that I wrote on Professor Goel. And I like this first line that I have written. Every significant advance in science has issued from a new audacity of imagination. So for every new invention or every new innovation, you have to have some kind of a thinking which is out of the box, and you have to take some new steps down new roads with nothing but your own vision. As we all know, Professor Goel has done this in many aspects, especially in skull base, in craniovertebral junction, and now we are going to see his hypothesis on spine. Professor Goel has been my mentor and is my greatest inspiration. So I will begin now, introducing a new concept, the Goel concept for spinal degeneration, Instability is the issue and stabilization is the treatment. So we have all been dealing with cervical spine, with cervical spondylosis. And these are the methods that we have been using. The anterior approach, we'll be doing multiple kinds of laminoplasties, multiple kinds of laminectomies with all varying results. We also in our department have been using these anterior approaches, used to be using these anterior approaches for multi-level cervical spondylosis. And we are all used to these kind of images where we have done multi-level corpectomies and discectomies followed by a fusion. Because once you remove these causes of compression and you believe that the spine becomes unstable and the fusion is performed to make the spine stable. So as we know in the anterior approach, it involves a lot of dissection. It involves a lot of retraction of the esophagus and the trachea. There is a risk of injury to the recurrent laryngeal nerve. And apart from, if it is a single level, it is a pretty straightforward procedure. But for a multi-level cervical spondylosis, it is a little cumbersome and may lead to quite a lot of morbidity. So this is just an image showing the multi-level cervical spondylosis and the techniques that are used, the decompression that is performed to remove the osteophyte, to make space, some amount of corpectomy, discectomy, and then the insertion of screws and spacers to stabilize the spine. Early on in 1997, Professor Goel also described this technique of tricortical cervical interbody screw fixation after an anterior approach. The strength of this was it involved 3 cortices. The screw traveled 3 cortices. This one, the one that is in below this about the disc space, and another cortice here. So basically it gave quite a firm stabilization to the spine after an adequate decompression. So this is how we have all been looking at cervical spine. Now we come to another hypothesis. The standing human position. We are in a standing human position, and the muscles that are responsible for the standing human position are all in the back. They are the strong extensor muscles of the back. The treatment of spinal spondylosis has been surrounded around the disc. It has been disc-centric. We believe that the disc degenerates, there is loss of water content in the disc space reduces, then there is osteophyte formation, there is ligament buckling, and everything revolves around degeneration of the disc. Now, what we hypothesize is that the weakness of these extensor muscles that are responsible for the human standing position is the primary problem in spinal spondylosis. The weakness of the muscles causes a facetal listhesis, which is the initiator of the cascade of events that leads to spinal degeneration. So vertical facetal instability, is it the point of genesis of spinal spondylotic disease? So this we believe, and I'm going to show you over the whole presentation how this has affected our practice. So this is the craniovertebral junction. Here you can see there is some buckling of the ligaments here. There is osteophyte formation in this region. There is a loss of facet space height. Here you can see some osteophytes in this region. These are all not primary. These are all secondary. The primary problem is atlantoaxial instability. And all these events, the buckling, the osteophyte, the space reduction, is secondary to this atlantoaxial instability. Similarly, this calcification in the region of the apical ligament, it is not some congenital problem. It is not an os odontoideum. It is an osteophyte. It is a calcification in the region of the apical ligament due to a vertical spinal instability that has led to the formation of this osteophyte in an attempt to form fusion in this region and make the spine stable. So how do we treat this? We treat this only with atlantoaxial stabilization. And this leads to reversal of all these events that have occurred in the presence of instability. So this was our article initially in 2010, where for the first time we had discussed this entity of craniovertebral instability due to degenerative osteoarthritis of the atlantoaxial joints. Similarly, retro-odontoid mass. A lot of times this has been viewed as a pseudotumor. It has been viewed as something that has to be resected by either a transoral approach or by a lateral cervical approach. and if necessary, then followed by a stabilization. But for the first time, Dr. Goel came up with this philosophy that this retro-odontoid mass, this retro-odontoid tissue, is a secondary event again to the primary atlantoaxial instability. It is a hypertrophy of the ligaments in the region that buckle due to the instability and due to the vertical collapse of the facets. And atlantoaxial instability without any kind of decompression reverses this event, as you can see in these images. So this is a patient that we treated. You see the retro-odontoid cyst in this region. The patient was treated only with atlantoaxial stabilization. And in the immediate post-operative period, this was done within 48 hours, you can see the disappearance of that retro-odontoid cyst. This is another patient. Here you can see the retro-odontoid tissue in the region of posterior to the dens, treated only by atlantoaxial stabilization. This is disappearance of the tissue in the immediate post-operative period. So basically, we likened retro-odontoid tissue to an kind of like an osteophyte, which resolved after stabilization. The similar event was observed in rheumatoid arthritis, where you have this pannus. The pannus is nothing but a buckling of the ligaments in the posterior aspect of the C2 vertebra. And after remodeling and making the joints and stabilization, you can have a reversal of these events. So then this was the intra-articular facetal spacer, was introduced in the year 2004 by again Dr. Goel, and this was made as in an attempt to stabilization and to form indirect decompression and stabilize the region. Coming to the subaxial spine, you see this C3 vertebra. You see the superior and the inferior articular facets, and see the huge amount of bone that is present here. Thick cortical bone that is present in this region that is available for use. It is even more in thickness than the breadth of your thickness of your vertebral body. This whole bone has been underutilized in the treatment of cervical spondylosis. That is one aspect. And the second thing is this forms the fulcrum of movements of the entire cervical spine. This is the area of focus. This is the area that malfunctions, where there is listhesis and leads to the whole process of spinal degeneration. So as you can see in the craniovertebral junction, here the facet of atlas has gone above the facet of axis. There is a listhesis here. And similarly, in the subaxial spine, you see this listhesis of the subaxial facets, where the rostral vertebra falls behind on the caudal vertebra. This happens due to your weakness, due to your physical abuse or disabuse of the extensor muscles of the neck, which you have not taken care of, leading to these events of spinal degeneration. So this loss of disc space height, as you can see in this image, this prolapsed disc bulges in the lumbar spine, in the cervical spine, this osteophyte formation, these are all secondary events that we believe are secondary to the primary factor, which is vertical instability of the facets causing retrolisthesis and buckling in the region. So to come back to this, vertical facetal instability is at the point of genesis of spinal spondylotic disease. So earlier in the year 2010, to solve this issue, we came up with these facet distraction spacers for the treatment of degenerative disease of the spine. The rationale was that the spacer, when inserted between the inferior facet of the rostral vertebra and the superior facet of the caudal vertebra, like you can see in this region, it increases the disc space height, it increases the intervertebral body height, it increases the distance between the interspinous ligaments, and it also increases the height of the interneural foramina. All these events were led to an indirect decompression and stabilization. So this was the earlier thinking that we had, that the radiological image is better with the decompression. So there was a decompression of the region followed by a stabilization just by introduction of these facet spacers. So these are a few images. As you can see, there is multi-level cervical spondylosis. You can see the disc bulges in this region, which has just been treated with multi-level facet spacers, as you can see in this X-ray. And you can see in the post-operative period, there is indirect decompression of the cord. There is an increase in the disc space height. There is increase in the water content in the disc space height. leading to a neodisc formation, and there is complete stretching of the buccal posterior ligament, posterior longitudinal ligament. Here you can see in this region, there is a disc bulge in this region. This has been treated with facet spacers. You can see that the disc bulge has disappeared. This is in quite an immediate postoperative period. A new disc has been formed. The vertebral height has increased. The interspinous height has increased. And believe me, the patient has had a remarkable clinical recovery, which happens in the immediate postoperative period that in all our patients. So there's another patient with a high cervical disc in this region. You can see the disc bulge, again treated by multi-level cervical facet spacers. The advantage of this technique is when you do a posterior approach, you can gauge the levels that require fixation by the status of the joint, by the status of the mobility of the joints, by the vicinity, by the status of osteophytes in the vicinity of the joints, and you can decide the level intraoperatively. You can also see with these subaxial facet spacers, the neck movements are pretty well preserved in this patient. And after 1.5 years, this is the beautiful fusion that has been obtained, and the patient is back to his normal life. This is another patient with multi-level cervical spondylosis, treated only with facet spacers. Here you can see, if you compare the pre and the post-op image, you can see the increase in the disc space height. You can see the increase in the interspinous height. You can see the loss, the decompression of the cord here, the formation of a neodisc, and at a later stage, you can see this post-operative fusion and stable spine. This is another patient with multi-level cervical spondylosis treated with multi-level spacers, and you can see the post-operative image. Another patient with a disc at the level of C3-4 treated by spacers. The level of spacers we decide on intraoperative imaging of the viewing of the facets. So this was our early experience, which was published in 2011. Facetal distraction as treatment for single and multi-level cervical spondylotic radiculopathy as well as myelopathy. And it was on the cover page of Journal of Neurosurgery. And this became our beginning of the journey of the hypothesis for spinal degeneration. I have performed a morphometric analysis of the cervical facets and measured the actual increase in the intervertebral foraminal height, in the difference in the interspinous height, and in the intervertebral body height by using the facet distraction technique, and the results are published in this paper. So this was a new concept where we used spacers in the craniovertebral junction in the atlantoaxial joints and also in the subaxial spine. And this is the image of the spacers that we use and which have now been patented, both in the US and in India. Similarly, this philosophy was extended to the lumbar spine, and you can see facet spacers that are used in the lumbar facets. And this was again another paper that we published with distraction of the lumbar facets with intraarticular spacers for patients with lumbar canal stenosis with remarkable results. Again, an anatomical and biomechanical analysis has been performed for this technique, which gives good stability. So up till now, when we believed that decompression of the compressed or deformed neural state system was important, and it has been the basis of surgical treatment for several decades. So using the facet spacers, we achieved a decompression and a simultaneous stabilization without removal of any disc, without removal of any ligaments, or without removal of any bone, with fantastic clinical results. But as we evolved in the management of patients with cervical spondylosis, Professor Goel realized that it is not just decompression that is important, stabilization is the most important thing. And this was our preliminary result with 6 cases with only fixation for cervical spondylosis. This was in 2013. And recently we have published our experience of fixation, only fixation for muscle weakness related spinal instability in cervical spinal degeneration. So these are a few of the patients. I will just quickly show you some images. And this is the method we use to perform the fixation. Just a transarticular screw fixation without any bony decompression or removal of any disc or removal of any ligaments in the region, with remarkable patient clinical recovery. I will not show you the patient videos because I will not have time otherwise. Here you can see this patient with a huge disc osteophyte ligament complex in this region, treated only by transarticular screw fixation. And this is a delayed image that shows a reversal of these events of spinal degeneration. Here you can see We have not done any kind of decompression. We have not removed any of this disc osteophyte ligament complex. And you can see that it has reversed. This gives credence to the hypothesis that it is spinal instability that is the genesis of spinal degeneration. Here is another patient. You can see the disc bulges in this region, treated only by transarticular screw fixation. And you can see the delayed image where all these spinal degenerative changes have reversed. And this is the patient. When he came to us, he just had a movement of his toe thumb. That is it. He was on the bed and unable to walk. And now you can see that he's easily walking, and he describes it in his language, which I will not be able to show you. This is another patient with multi-level cervical spondylosis treated only with transarticular screw fixation. And you can see the post-operative delayed image showing the alignment of the cord. There is no evidence of any compression and the strong fixation. So this is our hypothesis for degenerative cervical myelopathy, and many articles have been published on this subject. And we use the Camille's transarticular technique of spinal fixation with a little bit of modification from our part. Sometimes instead of using one screw in the facet joints, we use 2 screws, which gives additional stability. When we feel that the facets are having some issues, we use double insurance screws. And this is a modification of the Camille's transarticular technique of screw fixation. And it is an underused technique. Basically, the facets are very strong bones, and fixing them gives a very strong biomechanical stability to the spine. Again, these are a few images showing the transarticular screw fixation. You can see the preoperative cervical degenerative changes in the region, and postoperatively, you can see the alignment, you can see the fixation, and you can see the relief of cord compression. So this is just a small video showing the technique which we use. So you can see that this is the midline. These are the spinous processes with the interspinous ligaments. This is the region of the facets. The instability in this region is identified by the movement between the 2 vertebrae, by the vicinity of osteophytes in the region, and by the status of the joint. Sometimes you find the joints are completely open and unstable. Once you start doing this, you will realize this. And as we go further, this is on the other side. So this is, we identify the level of the facet that has to be fixed. You can see how open the joint is here. You can see the osteophytes in the vicinity of the facet joint. And this is the transarticular screw fixation, which is a tremendously safe technique. There is no risk of injury to the nerve root. There is no risk of injury to the vertebral artery. You have to learn just the angle, the trajectory of screw insertion. And we use 14 to 16 mm screws for transarticular screw fixation, as you can see now. Sorry. So now this is the screw fixation that we have performed. And multi-level screws are inserted in this region, and a strong fixation is achieved. After this, the bone is denuded, and if we do more than 3 levels, then we use iliac crest graft for fusion. Otherwise, we just use the local bone that is available for creating the fusion. So basically, we come to this conclusion that instability is the cause of symptoms and stabilization is the treatment. Not neural deformation or compression, but instability is the cause of symptoms in degenerative spinal disease. So what are the indicators of spinal instability? As I already discussed, you will come to know once you start doing more and more cases, and you will realize how many levels need to be fixed. Another important point is the role of atlantoaxial instability in patients with multisegmental cervical spondylotic myelopathy. If you see this image, here you see the facet of C1 is posterior to the facet of C2. We have identified this entity as central atlantoaxial instability, And in patients with multi-level cervical spondylosis, if we find this central instability or if the patient has severe symptoms, we include the atlantoaxial joint. As you can see in this image, patient presenting with severe myelopathy and type 2 atlantoaxial facetal instability, we include the atlantoaxial joint. Similarly, in patients presenting with severe myelopathy, we generally include the atlantoaxial joint for treatment. Another issue, is it necessary to resect osteophytes in degenerative spondylotic myelopathy? Now you see this image, you see this disc osteophyte ligament complex. You can see this huge osteophyte in this region. The treatment performed by us is only transarticular fixation. And you can see the delayed image. I think this is after 3 years, and you can see the fusion in this region, disappearance of this disc osteophyte ligament complex, as you can see in the postoperative MRI. And this is a recent publication where we have studied the outcome of osteophytes at a minimum follow-up of 12 months after only fixation as treatment for cervical spondylosis. Here you can see the disc osteophyte ligament complex, patient treated only with spinal stabilization, and you can see the postoperative image where there is no compression on the cord and a good fixation. Again, you see multi-level cervical spondylosis treated only with spinal stabilization and no decompression, and you can see the postoperative image showing no evidence of compression and a good fixation. So basically, we came to the conclusion that the term degenerative spinal canal stenosis can be a misnomer, and degenerative spinal instability is a more appropriate term. Now, to continue the journey of cervical spondylosis, we come to the issue of today, that is ossification of the posterior longitudinal ligament. So in our journey, we think that the ossification of the posterior longitudinal ligament is a continuum of the same event that leads to cervical spondylosis. So we all know OPLL. We know the types of OPLL, as you can see in these images. OPLL is an intruder into the spinal canal, and it has been treated as such. You think it is an intruder which is causing cord compression, and it is causing narrowing of the cord and causing clinical symptoms of cervical myelopathy. And the treatment for this intruder has been either an anterior approach, removal of the intrusion, and because you've removed the intrusion and created an unstable spine, you do a spinal fixation. Similarly, there are different kinds of anterior approaches where some people recommend removing the OPLL. Some people have a free floating method where you leave a part of the OPLL attached to the dura because there is a risk of CSF leak or cord injury if you try to remove the whole OPLL. And recently, there are techniques that describe anti-displacement of the vertebral bodies to relieve the cord compression. Similarly, there is a debate whether to do anterior approaches or posterior approaches. In the posterior approaches, whether to do a laminectomy or whether to do a laminoplasty. Generally, people now prefer doing a laminoplasty or a laminectomy with some kind of fusion, because now people have started realizing that the OPLL has both a static and a dynamic component. So this is the OPLL, and the exact cause of the OPLL is also still debatable. There are many genetic, hereditary, environmental, metabolic causes that have been labeled to cause the OPLL. We think that a sedentary lifestyle with a very obese body structure also contributes to the formation of OPLL. And why in some people OPLL that happens and in some it doesn't happen is still an answer that we do not have. So earlier, this was the technique that we used, that is a limited oblique corpectomy for treatment of posterior longitudinal ligament, which was described by Dr. Goel in 2005. And this was the technique where a minimal decompression, minimal corpectomy was done, and part of the anterior vertebral body was left. This caused an adequate decompression and avoided the need of stabilization. This was what we used to do earlier. But now, with our new concept of spinal degeneration, we have come to this conclusion that only stabilization is the ideal treatment for ossified posterior longitudinal ligament. This was our early experience in 14 patients, and you can see this huge OPLL in this region. Treated only, earlier we used to use facetal spacers for this region, for this OPLL, but now of course we have shifted to the transarticular screw fixation, and here you can see the post-operative image. This is another patient with huge OPLL, and you can see the transarticular screw fixation. And just with this transarticular screw fixation, without any kind of decompression, the patient has a remarkable clinical recovery, and we haven't had any kind of complications after this procedure. So this was our early experience in 14 patients, and now we have recently published our complete experience of 52 cases on as only spinal fixation as surgical treatment of cervical myelopathy related to ossified posterior longitudinal ligament. So there are a few images that I will show you. So here you see the OPLL in the region of the C1, C2 region. Here you can see the facetal instability in this region, and you can see the fixation that has been performed with transarticular screws. Again, huge OPLL in this region. And here you can see our modification where we have used double insurance screws to treat this patient with remarkable clinical recovery. This is another patient with OPLL in the C3, C4, C5 region, treated only with subaxial fixation and has a remarkable clinical recovery. Again, this is another patient with a massive OPLL. You can see here, and you can see post-operatively the decompression of the region, indirect decompression, and the transarticular screw fixation. As we moved further, in patients with high cervical OPLL, we realized that inclusion of the atlantoaxial joint was equally important to achieve a good clinical recovery. Sometimes missing the atlantoaxial joint can lead to a less than optimal clinical recovery. And so for high cervical OPLL, we recommend including the atlantoaxial joint in the stabilization procedure. This sent a review of a new clinical entity of central atlantoaxial instability. So in patients in clinical entities like basilar invagination, Chiari, syringomyelia, myelopathy related to cervical spine, ossified posterior longitudinal ligament, and in Hirayama disease, if you realize that the patient has a central atlantoaxial instability, then inclusion of the atlantoaxial joint becomes mandatory. Here you can see this patient with an OPLL, with a high cervical OPLL. You can see the type 2 facetal instability with an inclusion of the atlantoaxial joint in the construct. The other levels are included as per the visual examination during the surgical procedure. Again, another patient with a high cervical and a low cervical OPLL treated with atlantoaxial and multi-level subaxial cervical stabilization. Now, this is an interesting image that I will show you. You can see this region. There is just segmental OPLL at the level of C2, at the level of C3, at the level of C3, C4, and C5. If you see this image, if you see this region here, you can very clearly see the facetal listhesis. The facet of rostral, the facet of C2, which is the rostral vertebra, has retrolisthesed on the facet of C3, which is the caudal vertebra. And the patient has been treated with an atlantoaxial and subaxial fixation with a remarkable clinical recovery. This is another patient with an OPLL with a multi-level spinal construct, and I will show you this patient. This patient came to us with, she needed support to walk of two people. They had to carry her in her hand, support both her hands, and she was able to walk with minute steps. And this is a year after the surgery, and you can see how she's walking for yourself. She's running actually. This is the patient. This is the patient with OPLL, and this is the clinical result. And you can see the smile on her face, and this is the kind of clinical recovery that we are achieving in all our patients. She's actually saying that she was in her village, and when she was actually followed by a bull, and she ran so hard. She said if Dr. Goel could see her at that time, that he would be very happy. This is what she's saying. So this is the remarkable recovery that we are achieving in our patients with only fixation for ossified posterior longitudinal ligament. There's another patient with this ossification. Here you can see the patient is walking with a stick and slow steps, and here he's walking without any aid. Another patient with a subaxial cervical OPLL treated only with transarticular fixation. Patient presented with severe cervical myelopathy. We have included the atlantoaxial joint, and the C2 screw has gone from C2-3. So we have avoided injury to this high riding vertebral artery. So another patient with a huge cervical OPLL treated only with subaxial transarticular screw fixation. Again, another patient treated with both atlantoaxial and subaxial transarticular fixation. So this is our experience with OPLL, and you can see these are the levels involved and the number of levels we have fixed, and these are the types of OPLL. This we have recently published in World Neurosurgery. This is the pre-operative grading. This is the Goel clinical grading system that we use in our department. And you can see the patients pre-operatively and post-operatively. And this is the patient satisfaction index that we have devised. And you can see how remarkably satisfied all our patients are, except for one or two who are not satisfied. So this is the remarkable clinical recovery that we have achieved in patients with OPLL, where there is a high chance of morbidity and mortality with the other procedures that are being performed. So atlantoaxial and subaxial cervical spinal fixation, can it revolutionize surgical treatment of cervical myelopathy related to OPLL? And we recommend spinal fixation as treatment of ossified posterior longitudinal ligament. Based on this, we have a feeling that decompressive laminectomy for degenerative spondylotic lumbar and cervical canal stenosis may become historical in the future. And anterior transoral decompression, like anterior transoral decompression, will anterior spinal cervical surgery actually come down with this kind of philosophy? So from only decompression to only fixation, a century-long journey of surgical treatment of spinal spondylosis. Thank you very much. Thank you once again to Professor Kato and the ACNS. And thank you very much for a patient hearing.
Thank you, Vida, for a very, very nice presentation. And I can see Professor Goel in you. So yeah, just a few questions. I think there's no doubt about the, atlanto-occipital instability and, the role of fixation for that. But you have touched on a very, very interesting topic, which is the OPLL. And so my question to you is, you have presented quite a few cases, and patients who have come in with obviously with neurological deficit. So in our settings in my country, when a patient comes in with myelopathy, that is and especially weakness, the obvious or I think the most important thing that we do is look at decompression. So I think this is also not only it's also an ethical issue. Do you have any issue with ethical issues in your country? Because I mean, when you talk about compression, and you're doing a sort of like a fixation. So do you have any problems with that in your country?
No, we haven't not had, but we elaborately discuss with our patients before doing the surgery. We explain to them what we are going to do. And we also tell them, just in case that there is no problem, we can, in case he does not improve, we can always go in and do a decompression, either anteriorly or posteriorly. But till now, we haven't had a chance to do this decompression because all our patients have clinically recovered. But we do explain to them pre-op, and none of the patients have given us any issue with this.
And is the recovery instantaneous, or it takes some time?
Instantaneous. In the evening of surgery, the patient will say the movements of the fingers are free, the tingling has reduced, the stiffness has reduced. You have to come and see it for yourself. It's magic. And
also the other thing, because to what we are experiencing now, we are actually going away from fixation. We are going away from fusion. We are going away, especially for degenerative disease. I think the world is going away from surgery. Like what you just mentioned, we're going on core muscle strengthening, which is very right, whether it's the cervical, lumbar, and you are going back into fixation. You look at the East, you look at Japan, they are going into minimally invasive surgery, muscle sparing, laminoplasty, okay, where you don't put in instruments. I see even for a 2-level OPLL, there is, I'm sorry, maybe you can explain. I see 4 or 5 levels. That means you are, and you're subjecting patient to a bigger surgery. So what is your strategy on that, and maybe for the younger people?
Yeah, so our strategy is we open the spine. We do a complete exposure. We are not doing percutaneous. We always find that the muscles are weak, they're flabby. After retracting the muscles, we assess the stability of the spine, and we assess the facets. We assess the soft tissue and the osteophytes in the region of the facets. And depending on that, we decide the level of stabilization. if you realize that everyone who does cervical spine surgery has the issue of adjacent segment degeneration, where after a few years they have to come back and do the second level. By doing this, by identifying the levels of fixation at the primary stage itself, we are addressing, I believe that we are addressing this issue of adjacent segment disease also by doing a fixation of the involved segments, of the affected segments at the first stage itself. So that is our rationale. We assess it intraoperatively. Actually, I don't have too many videos, but if you come and visit us, you will be able to clinically gauge that this level is unstable after a certain while.
Another question is, you also mentioned that you do intraoperative decision to fix a level. I just want to find, because I mean, in this age of medical legal awareness, in my country we can't do that. We can't tell, okay, we're going to go in and maybe we're going to do this level. So how do you come up with that strategy?
So you have to treat the radiological level. That is per se. You have to treat, obviously you're going to treat the radiological level that is involved. I'm talking about assessing the level above and below intraoperatively, and if it is involved, it feels unstable, or there is too many osteophytes, or if the joints are open, then you address that at the same time.
So that means you get a consent. How do you get consent for the patient? That means you say, is a KIV, if I do, I mean, how do you do that? Because consent is very, very important. So how do you take a consent for the patient? Do you just say a blanket, okay, I'm going to do 3 levels or 4 levels, or how do you do that?
We actually tell them that, see, depending, suppose there is a 2 or 3 level involvement. So we tell them 3 levels are going to be fixed anyways, any which ways. But if we think that a level above or a level below needs fixation, then we will go ahead and do the fixation. We've not had an issue. And if we are going to include the atlantoaxial joint, most of the times we know preoperatively that we are going to include the atlantoaxial joint. We inform the patients accordingly.
I see.
As our experience is growing, we are able to make the decisions pre-op also, rather than just relying on intra-op. Of course, intra-op is the most important, but we are able to gauge and decide pre-operatively that probably this patient will need so many level fixation.
Yeah, I'm sorry, but I think in maybe you can, I'm sorry, but maybe in India you can do that intraoperatively. But I think in most other countries we don't have the luxury because there is a lot of I don't know how it is in your center, but medical legal litigation is very, very high, and it's very, very difficult. If you do not tell the patients and you do not document it, it's getting very, very, very difficult for us. Maybe in India it might be different. Yeah, thank you. Any other questions from any of the members of the faculty?
Yeah, sure. Then there should be questions. It's a very controversial point. May I call my co-host, Dr. Liu?
Yeah, thank you, Raja. Thank you, Prof. Adiba, for very nice eye-opening lecture for us. I just want to find out from you 2 main questions. And you seems like shifting from a distractor of facet to a facet fusion. And I see a lot of advantage of distracting the facet where you actually increase the foramina, especially for neuroforaminal stenosis. But at the same time, you did show some images. There's some T2 signal of the disc anteriorly. It may be due to a regeneration of the disc. At the same time, also it may also indicate some form of injury. Is that the reason why you shifted from distractor to fusion? Another thing is, and you talk on the instability. And does it mean that with the distractor, the fusion rate are lower than the intra-articular facet screw? Or why there's a shift from distractor to screw? My second question is, I see a lot of scan of you that you don't really concern about so much of correction of cervical lordosis. And that mainly probably due to you, in some people that think that the changes from cervical lordosis to straight spine is adaptation of the physiological of the body. So you don't attempt to change it because you do not want to cause more instability. Can you comment on that? Thank you, Prof.
Yes, so your second question, yes, I agree with what you said. So we do not check too much about sagittal balance. We fuse in the best optimum position that the patient has. For your first question, we shifted from distractor to fixation because the hypothesis, the understanding changed from no need of decompression to only stabilization. So we were using the facets to the spacers to form an indirect kind of decompression because it increased the vertebral body height, it increased the neural foramen height. So this is early on we thought it will there will be a decompression as well as stabilization. So as the understanding evolved that the decompression is not necessary, as you can see, I have shown you images where the osteophytes have gone, the disc osteophyte ligament complexes have gone with only a screw fixation, no need of any kind of indirect decompression also. That is how the philosophy changed. The fusion rates for both were spectacular. There was no problem in either of the cases. And we still use spacers sometimes. It is not that we don't use. Sometimes we use them intermittently, but predominantly we are doing a transarticular screw fixation.
Yeah, one more extra question. Do you need to prepare the facet for the fusion to increase the fusion rate, or just okay?
No,
Any special way to prepare the facet for the fusion?
So we insert an osteotime in the facet, we denude the facetal cartilage and all that area, and then sometimes put small bone chips also inside it, and then do a screw fixation.
Thank you, Professor.
Sorry, can I just make a comment?
Yeah, sure, why not?
Yeah. Thank you very much. I think the take-home message, especially to the younger guys, is I personally believe in spine because that's my area of interest. I believe there's never just one way of treating the spine. You know, like what you just said, Vida. Like you initially, like even from your own journey, or Prof. Atul, who is very well known in his CV junction and spine. Things keep changing. Sometimes, and it used to be anterior, then it went to posterior, then anterior. First it was anterior posterior, then 360 degrees. Then we went into laminoplasty, and then we went into different things. I think the message that we all have to understand is like there's various pathologies. When you're treating OPLL is different from osteophyte. There's always it's all different, So I think the most important to me is actually to identify what is the causative factor and then treat it accordingly. So it's a very, very good thing because I think what Prof. Atul Goel has done is fantastic. I mean, he has really given a different dimension to especially CV junction pathologies, and it's very good. But I would think the most important thing is for us to treat, to understand the pathology and treat it accordingly. And also fixation is something that we really need to think of, because like what you just mentioned, yes, it is, when we are going to do fixation, yes, of course, when you restore the normal anatomy by putting a spacer, of course, you will sort of give a little bit more space and reduce the compression. So it is good. But having said that, people like me who are very, very conservative, who are not as brave as Professor Goel, we are a bit skeptical on that. But anyway, very, very good presentation. Thank you very much. And with that, I think, if there's no other questions, Dr. Raja, is there any other questions?
Yeah, I would just like to ask Professor Shah one more question, that how do you assess fusion in your patients? Do you take a flexion extension X-rays? And if yes, then what is the non-fusion rates that you have come across in your technique?
They've not come across non-fusion. You saw the images that I showed. So fusion we assess by both flexion extension images and also by the bone formation posterior to the facets and between the facets. So if you've seen some of the images I've shown, there is very strong bone formation posterior to the facets and in the facets. So that is how we assess the fusion. And we haven't had screw displacement, cage displacement, we haven't had any of those issues. Dr. Kanta, you should try this once. Believe me, it'll change your thinking. You should try this. As for the fusion that you were mentioning, especially for OPLL, people do believe nowadays that the dynamic component is more important. And there are quite a few papers that do say that just when only a laminectomy has been done without fusion or just a laminoplasty, there is progression of the OPLL. Whereas when it has been combined with a fusion, the OPLL stops. I mean, it does not progress at least. So of course, it is a very controversial topic. But I think fusion is important, especially for OPLL. And secondly is, I would say that you come to our center and you visit us once, and then you will see the difference. Because we
So
used to
that is,
practice surgery too,
okay,
and we've
that is the
changed.
next question. That's the next question I'm going to ask you. For OPLL, like what you mentioned just now, with solid fusion, that is where we are also now going away from fixation because, I mean, if you look at the proper, when you have OPLL, right, do you all do fixation? I mean, do you think there's necessary to do fixation in OPLL?
Yes, that is what
I
I'm
mean,
saying.
with distraction, does it make, from your experience, does it make a difference when it's already fused with OPLL?
Yeah, so what the others are doing is, once you're removing the OPLL and then they are fixing it, right? We are stabilizing the spine, because the OPLL has both a dynamic and a stable component, right? So the dynamic component is not being addressed if you just do if you don't do a fusion. I think that dynamic component is definitely the more important factor, and I think definitely we are doing fusion for it, and I would recommend doing a fusion.
Right. That was very
Okay.
interesting discussion. Thank you very much. As Professor Raslingam said, that there are more than one ways to build a cat in cases of cervical spine diseases. I hope our first chair, Professor Sanford, is with us. Before we conclude this session, any comments from Professor Sanford?
First, congratulations, Professor Shah, for his good, very excellent lecture. But actually, I'm not doing spine surgery, but I have no any, dare not have any comment for Dr. Shah. Thank you, Dr. Shah.
Right.
Thank you, Dr. Sanford.
So then we'll wind this up officially. On behalf of the Education Committee of the ACNS and the President, Professor Yoko Kaita, I would like to sincerely thank both the speakers for today, Professor David Adelson, Professor Abhida Shah, and the chairs, Professor Kanda Rasalingam and Professor Sanford Su, for coming here and teaching about their wonderful subspecialties about pediatric epilepsy and cervical spine. Thank you, Dr. Liu Boon Seng, for being my co-host for today. So until we all meet on next Saturday, it is bye-bye from all of us. Thank you for joining.